Hi, from here for next few videos, we'll be discussing about some topics in oral pathology. So, we'll be starting with developmental disturbances. First coming with developmental disturbance of jaws. So, developmental disturbance of jaws, I have divided into 4 videos. The first video, this one will be discussing about Agnathia, Micrognathia and Macrognathia. And the further coming videos, we'll be discussing about the other developmental disturbance of jaws. So, first coming to Agnathia. From the term Agnathia, we can understand what this is. That is, A means absence and Nathia refers to the term jaws. So, Agnathia is there is absence of jaws. There is defect in the complete development of jawbone, then we call it as Agnathia. So, first we will see what are the other names. The other names are autocephaly, hollow prosencephaly, Agnathia. Then just the intro to Agnathia. So as told from the name we can understand Agnathia is there is absence of jaws. There is absence in the complete development of jawbone. And when you see maxilla or mandible, it is mostly affected. Both are affected equally. And it is not that there can be complete absence of mandible or complete absence of maxilla. Sometimes it can be also a partial absence. So either complete or partial absence of mandible or maxilla is seen. And it's a lethal anomaly. It's a very critical if happens. And but whereas the prevalence, if you see the prevalence rate of Agnathia is very less and very less number of cases has been reported so far. But if it is very severe, it can be lethal. And this can be also inherited. If it is inherited in an autosomal recessive mode of inheritance. So we'll see Agnathia of maxilla and then Agnathia of mandible. So in maxilla, when you see either the maxillary process or the premaxilla, either maxillary process development is affected or the premaxillary region development is affected. It can be that totally it can be absent or also there is some developmental defect. In such cases, you can see maxilla. So you can see that middle third of the face will be completely retracted in these patients when there is complete absence of maxilla. Next coming to Agnathia of mandible. So Agnathia of mandible, it can be either unilateral or bilateral. Most of the times it's unilateral. The prevalence of unilateral is more like one side of the mandible is affected whereas the other side can be normal. And also condyle can be affected or entire ramus. Most of the time it's like the development of condyle is affected. So you know the development of condyle is also important for the growth of the body of the mandible and ramus of the mandible. So when the development of mandible is affected or even the entire ramus can be affected and this can be also mostly unilateral. All the literatures have shown cases where there is bilateral absence of condyle or bilateral absence of ramus. Most of the cases it is unilateral absence. And when there is absence of mandible, of course there will be abnormality in the positioning of ears. There has been a case or image reported where the mandible is completely absent. So when the mandible is completely absent, what happens is usually the ear position will be here in the face. The ears can be positioned somewhat below the nose. There has been cases reported like that also. The nose will be here and the ears can be positioned very abnormally, giving much difficulty to the patient cosmetically and functionally. Whereas remember, most of the time it's unilateral absence of the mandible. The one side there will be complete absence of the mandible bone, whereas the other side there can be development of mandible. Now coming to the cause, like how is it happening is, this is due to the failure of migration of the neural crest cells. When there is no migration of the neural crest cells into the maxillary prominence region, we can see Agnathia happening. And this happens during the intrauterine life at about 4 to 5 weeks. At about 4 to 5 weeks of gestation, when there is no proper migration of, when there is no migration, it's not proper, when there is no migration of neural crest mesenchymal cells into the maxillary prominence, we see Agnathia. Next, we'll be seeing about Micrognathia. Same as Agnathia, here also when you divide the word Micrognathia into two, micro means small size. Gnathia again refers to the term jaw. So Micrognathia is, it's a small jaw. It is small than the normal anatomical size. When your maxilla or mandible is small than the normal anatomical size, then we call it as Micrognathia. Same as Agnathia, it is also a lethal anomaly which can lead to death. And here also both mandible and maxilla can be affected. Now, when coming to Micrognathia, we have two types of Micrognathia, that is true and false, also called as pseudo-micrognathia, true or false micrognathia. The true micrognathia is further of two types, congenital and acquired. First, we will see about true micrognathia. So, what is true micrognathia is, for example, if there is micrognathia of mandible, this is a normal mandible. Okay, so imagine this is the normal mandible. Okay, so in true micrognathia, you can see the mandible size will be small. The size of the mandible will be affected. The size will be affected in true micrognathia. The size will be smaller than the normal size. Anatomically, the size is affected. This can be for both maxilla and mandible. And this can be congenital. That is, during the time of the birth, the child can have true micrognathia. Mostly when it is congenital, it is associated with syndrome or with heart diseases. So, it can be due to the presence of any other syndromes. The fetus may have true micrognathia at the time of birth. So, mostly commonly associated syndrome is the Peri-Robin syndrome. So, the Peri-Robin syndrome we will be discussing in the next video. It is also a developmental defect of jaw. So, when it is with syndrome, you can write Peri-Robin as an example. Then it can be also due to any other cardiac diseases. The cause of congenital micrognathia is unknown. It is idiopathic. Next, coming to acquired. Acquired is, it is postnatal. It is after birth. Due to some reasons, the person is acquiring the micrognathia. The development of jaw is affected and thus the anatomical size is becoming smaller. So, the growth of the jaw is affected. So, there will be no further growth. Mostly after birth, it can be due to trauma, infection or ankylosis of the temporomandibular joint. Due to any of these reasons, the growth will be retarded, leading to micrognathia. Next, we will say about pseudo-micrognathia. So, pseudo or false micrognathia, also called as apparent micrognathia, is an illusion effect. Here, the jaw size is normal. There is no micrognathia. That is, jaw size is normal, not like true. True, the jaw size is affected. The jaw growth is affected. Whereas pseudo, the jaw size is normal. Here, the growth is not affected. But when you see the patient clinically, it is an illusion. It provides an illusion effect that the jaw is smaller. So, it is called as pseudo-micrognathia. It is mainly due to three reasons. First is due to the abnormal positioning of the jaws. Next is due to the abnormal relationship of the jaws. And third is due to the abnormal relationship of mandible with the skull. That is, imagine this is your skull base. So, this is a normal position where your mandible will articulate with your skull. Whereas, in pseudomicrognathia, it can occur that your skull base is here, but your mandible has been in a relationship posterior than the normal. So, this is the normal relationship. If your mandible is positioned posteriorly, then your relation, it can be giving a illusion that the size is smaller. Whereas the size is normal, only it is positioned posterior in relation to the skull. Then we will see about micrognathia of maxilla, micrognathia of mandible. So, micrognathia of maxilla is mostly due to the deficiency of the premaxillary region. And clinically, your middle third of the face will be retracted And also it said that mouth breathing can be the cause of micrognathia, whereas there is a different opinion, completely different opinion is that due to micrognathia, the patient might have developed mouth breathing. So it is like there are two opinions. Due to mouth breathing, there can be development of micrognathia, or due to micrognathia, there is development of mouth breathing. But due to as micrognathia is developing, the patient will eventually develop mouth breathing, and also there can be effect in the nasal and pharyngeal structures also. Next, mandible. When you see the mandible, so this is your maxilla and this is your mandible. When the mandible is retruded, so your chin area will be retruded. So your lower third of the face, the chin area will be completely retruded. There will be severe retrusion, there will be deficient chin button, and also steep. The mandibular angle will be, there will be a steep mandibular angle. So this is about micrognathia of mandible. Next we will be seeing about macrognathia. Macro means large. Again, gnathia is jaw. So macrognathia is large jaw. Here either only the jaw can be affected, only the jaw can be larger in size, or the endoskeleton can be affected. Most of the time it's the jaw which is only affected, but it can be that the endoskeleton is affected. When the endoskeleton is affected, it can be associated with conditions like acromegaly and pituitary gigantism. Then there are conditions of bone which can lead to giant jaw, large jaws. That is three conditions: Paget's disease of bone, acromegaly, and leontius ossia. These three will be seeing in diseases of bone in oral pathology later. So Paget's disease of bone will affect the maxilla. Acromegaly mostly affects the mandible, and leontius ossia also affects the maxilla. So only acromegaly affects mandible, when the other two affects the maxillary bone. Now what is the etiology of macrognathia is also most of the times unknown. It is idiopathic, but it can be hereditary in few cases. So most of the time when compared to mandible and maxilla, larger jaw is seen in mandible. So most of the time mandible is affected than maxilla. So we need to know what are the reasons how this mandible protrusion is occurring, or how you see the mandible to be in a larger size. So first scenario is in cases where you are, imagine this is your maxilla and this is your mandible. So in cases where your mandible is normal, whereas your maxilla is small. So this is normal size and maxilla is small. So when you see clinically, it is seen as mandibular macrognathia. Next, mandible is large and maxilla is normal. So next is when your maxilla is normal, but your mandible is larger. So again this is a true macrognathia. Here your mandible is larger. Next is increased angle between body and ramus. So this is the body of the mandible and this is the ramus. So when the angle between the body of the mandible and the ramus is increasing, it will be a larger size and it will be macrognathic mandible. Next, increased ramus height. So when the height of the ramus is more, when the ramus height is more, then it is going to be a larger size of the mandible. Then increased mandibular body length. So when the mandibular body length will increase is when there is an increased condylar growth. So when condylar growth is also increasing, then eventually the body length of the mandible will also increase. So it will be seen as a mandibular macrognathia. Next, increased gonial angle. What is gonial angle? Is the angle between posterior surface of the posterior surface and the lower border. So this is the posterior surface and this is the lower border. The angle between these both, posterior and lower border of the mandible, is a conial angle. When this angle increases, so normally the angle will be like this, means in case of macrognathia the angle will increase. So when this increases, you can see it as a large mandible. Anterior positioning of clinoid fossa. So you know clinoid fossa is where your condyle will get position. So this is a normal position of the clinoid fossa. In case of macrognathia, what happens is, if your clinoid fossa is more anterior, your mandible will also get located more anterior. So it will be seen as a larger size, whereas the size can be normal, just the relation of the mandible to the clinoid fossa can be abnormal. Then decreased maxillary length. When the length of the maxilla is less in compared to the mandible will be showing an illusion of larger size. Posterior positioning of maxilla to the cranium. So imagine this is a cranium, this is your maxilla and this is your mandible. When your cranium is so much posterior, that is, for example, it is so posterior, then your mandible will be located anteriorly. So it is also a illusive effect of showing mandible in your larger size. So posterior positioning of maxilla to the cranium, to the base of the cranium. Then prominent chin button. When your chin button is more prominent and also due to some soft tissue contours. Then what is the treatment for this? So of course we have to go for resection, mandibular resection surgeries, where the size of the mandible can be corrected and functional and cosmetic correction can be done. So that's all about Agnathia, Micrognathia and Macrognathia. Thank you.